which was compressing and splaying the right hepatic vein with a prominent inferior right hepatic vein draining the tumor. Interestingly, the patient had a type 3 portal vein anatomy in which right posterior pedicle came out early. These were the port positions. We used 12 mm port during for camera during parenchymal transection. So we began with mobilizing the ventral portion of the liver, taking down the falciform ligament, and we tried to mobilize, but in view of the big size of the liver, we were not able to mobilize superiorly and laterally. So we decided to take that down after parenchymal transection. We then proceeded with the hilar dissection. So there was a small bleed during the hilar dissection. So we applied a Pringle maneuver. So once we applied the Pringle maneuver, we were able to locate the bleed from the small branch of the right posterior portal vein. So that was controlled, and then we further proceeded with the dissection of the right posterior portal vein. It was a bit easy in this case because of the type 3 portal vein anatomy, in which the right posterior portal vein came out early. And once this was looped and clipped, we then dissected the artery. Again, the right posterior sectoral artery came out early, and that was divided. And the right posterior portal vein was clamped with the help of a bulldog. We started seeing the demarcation line. We then shifted our camera to the 12 mm port position, which was in the right side of the patient. So we used a crush clamp technique with the help of thunderbeat. We proceeded superficial transection, and then deeper transection we typically use the crush clamp technique. So we used to crush clamp, and then we saw small branches of the right hepatic vein or the inferior right hepatic vein draining the parenchyma, which was then taken down between the clips. Those were the small branches. As we progressed from caudocranial position, we started finding branches of the right hepatic vein draining, and the tumor became a bit compressible now, allowing us to proceed in between the tumor and the right hepatic vein. So inferiorly we divided the caudate lobe, and the inflow was divided using a tri-stapler Golden. And then we proceeded with trying to divide the right liver attachments to the periphery by taking down few triangular and coronary ligaments. And then we used two staplers, wide stapler, one for the division of the inferior right hepatic vein, which was taken down with a 45 mm wide cartridge. Since the right hepatic vein was on the tumor supplying it, we decided to take down the right hepatic vein also. So most of the portion of segment 8 was being drained into the middle hepatic vein. So that's the IVC. We created a space between the IVC and the tumor. What was remaining was just the right hepatic vein, which was again taken down with the help of a 60 mm wide stapler. So once we did this, as we can see, the tumor became compressible, and we mobilized the rest of right coronary and the triangular ligaments from the superior. Because of the sheer weight of the remnant liver and the narrow space available, we were not able to take them down with the help of energy release. So we cut with the scissors those triangular and coronary ligaments, and the specimen was extracted through the phenol incision. After this, the tumor bed was seen. The patient actually had a de novo tumor. Hepatitis was negative, and AFP was normal in this patient.